So basically, what happened with India is India was a poor country when it got independence, and the health issues, there were diverse health issues, and most of them pertaining to those people who were having very bad, I would say, social determinants of health. Okay, that can be income, that can be education, awareness, unemployment, work-life condition, food insecurity, malnutrition, gender, etc. So, because of lack of social determinants of health, it was found that the bulk of Indian population they live in rural India where health facility is very less, and we had paucity of doctors. The doctors or the trained professionals were also not there. Okay, so to get over this thing, to provide some basic primary health facility, you cannot have though that many doctors who will go and talk to people. And even if the doctors will go and talk to people, the people are not going to listen to them. Why? Because most of the health issues in the villages are concerning the child and mother and child. Okay, and when it comes to a conservative village of India, there are three things which are required. The first thing is trust. The second thing is language. Okay, there should be trust, language, and gender. Now, the gender of those, initially the doctors, in most cases, they were men. It is a new trend that women are going into medical field. They were not even educated in the early India. So there were paucity of doctors, female doctors, okay, or female volunteers. So what was required is a healthcare volunteer, a person who is aware of some primary health, who is a woman, number one, who can interact better with women. Number two, they should be local, because if you will go from some city or some other place, you won't be knowing the local language. So language barrier can be there. Apart from language barrier, if you are not from the community, then there can be trust barrier. So there were some committees. Okay, for example, Mukherjee committee was there first, then came Kartar Singh committee, and lastly Srivastava committee came, and they all recommended in some way or the other there should be semi-medical professionals who will guide primary health in the rural villages, okay, or rural areas, and they will communicate with the women, and they can talk also about some of the taboo topics. The taboo topics were those topics which women will not feel comfortable talking about with any doctor. Okay, so basically, community health volunteers or workers are lay members of the community. This is a strength rather than a weakness. Okay, this is whenever you have to convince somebody to take vaccine, a member of community can convince better as compared to maybe outsider who works either for pay or volunteering basing in association with the local healthcare system. So whatever policies and program is there, the community health volunteers are integrated with that. Okay, in both urban and rural environment, the community health workers usually share ethnicity. This is very important. Language, socioeconomic status, and life experiences with the community member they serve. This point is very important. Okay, they have been identified by many titles such as community health advisors, advocates, promoters, volunteers, educators, etc. Okay, so that is the different names. Now come to Mukherjee committee. So during that time, what was happening, as I told you, there was a need felt because of mainly the delivery, and there should be some aya or dai or midwives who will assist a woman in the delivery, in proper delivery. So The Kartar Singh Committee of 1973 recommended that there should be one ANM, okay, midwife available per 10,000 to 12,000 people at least. That was the thing. And she will be knowing some basic, things which are important for women health. In 1975, the Srivastava Committee recommended immediate action for what? For creating or creation of bonds of professionals and semi-professionals, health workers from within the community itself. So that is why suppose a question like vaccine hesitancy or something is coming or immunization is coming, you can see that people in rural India are better convinced by those people who are from their own community. Suppose a volunteer is there who is living in Maharashtra. Now he will go to Orissa and try to convince the people out there, the tribals out there, they are not going to be convinced. But suppose you are going there, you have to convince somebody to take vaccines. Then you can go to the community health volunteers or some leaders, community health leaders, then you will be listened. They will be listening to you. Now we'll come to the first thing. So rather than volunteer, it is a thing, and some of the people who work there, they are called Anganwadi workers. So what is Anganwadi? Anganwadi pertains, connotes to two things, child and mother. So Anganwadi is a type of rural child care centers in India. It was started by the Indian government in 1975. It was a part of Integrated Child Development Service (ICDS) program to combat child hunger and malnutrition. A typical Anganwadi center provides basic health care in villages. It is a part of Indian public healthcare system, basic healthcare activities, including contraceptive. So see, these are those things which are taboo, especially in conservative society of rural India. Counseling and supply, nutrition, education and supplementation, as well as preschool activities, all of them comes under that. The center may be used to as a depot for oral ORS, oral rehydration salt, which is very important for tackling malnutrition, basic medicine and contraceptive. So this comes under the Ministry of Women and Child Development, Anganwadi workers, now ASHA workers. So they came under National Rural Health Mission in 2005. An accredited social health activist is community health worker employed by Ministry of Health and Family Welfare. So that was Ministry of Women and Child Development. It is Ministry of Health and Family Welfare. Okay, that is the thing. As a part of India's National Rural Health Mission, the idea behind the accredited social health activist was to connect the marginalized community, okay, the marginalized community to the healthcare system. This was the concept behind that. Okay. The target was to have ASHA in every village in India. ASHAs are women. Number one, they are women who are trained to act as health educator. Number two, they are health educator. They are women who are also health educator and health promoter in their communities. The Indian ministry described them as, the Indian ministry means the Ministry of Health and Family Welfare. That described them as health activists in community who creates awareness on health and its social determinants and mobilize the community towards the local health planning and increased utilization and accountability of the existing health services. Some of their tasks are promote institutional delivery, immunization awareness, family planning, like surgical sterilization, use of contraceptive, then benefit of breastfeeding, then promoting menstruation, hygiene, etc. So why they can do that? Why not other people can do? that job effectively because of number one, they are women, they can talk about the taboo topics. Okay. Number two, communicate in the local language, local dialect. Number three, belong to the community, thus have a better trust level. So these are the three basic factors. In 2022, what happened because of their role in COVID vaccination, India's ASHAs were awarded by WHO's Global Health Leaders Award. So there were six awardees. Okay, among them, they were one of them. So you have to mention this. Global Health Leaders Award and have been recognized. They have been recognized and awarded. Recognized and awarded for their outstanding contribution towards protecting and promoting health. So what they do, pre-birth and post-birth, that is ante and postnatal, then institutional delivery, immunization, targeting malnutrition like ORS, giving ORS, family planning, then malaria, pregnancy, survey of health and related events, community, mobilization. So they will work and function for these things and more. Okay. So this you can speak about this and more. Now come to a similar concept is there for slum areas. Okay. So in slum areas, you have the Urban Slum Health Action Program. You have something called Urban Slum Health Action Program. Under that, you have USHA workers. USHA was launched in 2014 in Gurgaon and Delhi with the aim to detecting, treating, and preventing anemia and malnutrition among mothers and children. The project is being implemented in 8 slums in Gurgaon with the support of Wipro Cares, 8 slums in Delhi with the support of Fidelity International, and 6 slums in Gurgaon with the support of Krishna Maruti. Now, the project aims to improve the maternal and child health status of mother and infant, reduce infant mortality and morbidity among children and mother, and improve overall knowledge, attitude, and practice of communities toward, you know, MCH, mother or maternal and child health. This is very important and nutrition. Now, let's see some of the problems which ASHA face. ASHA workers face multiple challenges, including overwork, underpayment. Underpayment is a thing they are paid on incentive basis. Okay, despite their critical role, they are often overworked and underpaid despite receiving minimal. Whatever their salary is, there it is not salary. They are given honorarium because it is a honorific work. It is a volunteer or work. Okay, and performance based incentives. So this is the first challenge. The second is health risk, that is their demanding work schedule, okay, coupled with inadequate nutrition and sleep puts them at risk of anemia, malnutrition. So they have to actually look for this, but they themselves become a victim of this if they will not take care of themselves. Lack of autonomy, they have limited control over their time, finances, and well being, exacerbated by delayed payments and out of pocket expenses. Then, workplace violence is also there reported. ASHA workers sometimes face abuses, harassment, and assault within the communities they serve. So, Ghandwari Devi was raped. Why she was raped? Because she was stopping child marriage. Okay, the Vishaka guideline came after that. In a similar way, the health volunteers they will also stop certain superstitious practice and they are targeted at times. Environmental challenges, extreme weather conditions pose additional health risks and operational challenges with insufficient protective measures in place. Now, in a positive move, in a positive development, the GOI, Government of India has announced the expansion of health insurance coverage for community health volunteers under Ayushman Bharat. So this is a positive move you should say about this. Okay. Now come to midwives. So auxiliary nurse, midwives, they are there for a long period, is a village level female health worker in India who is known as first contact person within the community and health service. Okay. And then ANMs are regarded as the grassroots workers in the health organization pyramid. Their services are considered important to provide safe and effective care to village communities. The role may help communities achieve the target of National Health Program. Now come to if a question comes upon this, or if you have to say something in the interview upon them, what you are going to say. When you are going to say yes, you can add the information rather than talking about three of the committees, you can talk about one committee. Okay. If you will talk about three committees, you might not be able to speak the other points. Okay. Number one. The main point here is why ASHA workers are women. Why they are from community. If somebody will, ask you that you should rather send some educated people, then you can say the community people who are from their community are although not educated, but they are well versed in the local dialect. Okay, well versed in the local dialect means not literate, but they can make them understand in the local languages. Okay, suppose the travel village is there, so there also if you will employ the locals, they can interact in their own languages, and that is why they have more trust issue. So these 3 points you have to highlight somewhere. You have to say they are women, so they are better connect with women with trust. They belong to the community, so they have trust. Double trust is there. That is why they can also speak about benefits of breastfeeding, family planning, contraceptive use, and promotion of hygiene, etc., which other people cannot do seamlessly or very smoothly, easily, because there is a shy factor in the conservative women. Okay, that is one thing. This is the main thing you will say Srivastava committee, you will say why they are so effective because of these factors. You will say when Anganwadi came in, when Asha workers came in, and you will also say lastly they were awarded in 2022, and then you will say that in a positive move, Ayushman, they have been brought under Ayushman Bharat Yojana. So these are the main things you have to say. Okay. So the next class which I will take will be on National Family Health Survey number 5. And whatever we can derive learning from that survey, we'll see that. So I will stop here only. If you have a question, you can ask.
Sir, can you please explain the difference between catastrophic health expenditure and out-of-pocket expenditure?
See, out of pocket expenditure is what? ASHA workers or community health volunteers are there for what? They are, there are certain things which are preventable, which we can prevent by some means. Okay. That that section becomes a very important part of public health. The main target of public health is we should avoid preventable disease जो कि हम avoid कर सकते हैं. Now there are other diseases which are called, contingency disease. Contingency, not disease. I would say contingency mishaps or any health issue. Suppose a earthquake came. So that nobody can check earthquake. Nobody can stop earthquake. It can come anywhere. Suppose there is a nuclear bomb disaster, or suppose, beyond that, there are certain things like, pandemic or epidemic can emerge after flood or drought. So that is there. But here we are talking when we target the public health challenges. we should first target those challenges which we can do away with proper awareness or proper role of community health volunteers or the government. So there are certain things like malnutrition, like anemia, like deficiency disease, like communicable disease. If we can spend some money on, spraying DDT or something, then, or suppose if we are providing every household with tapped drinking water, we will be not having communicable disease or the so-called waterborne disease. So that is a good move. So why not to spend in the social capital and provide them tap drinking water which is safer, rather to force them to drink something which is very harmful for them. Similarly, there are other examples also which are preventable disorders, disease. There are other disease disorder which are not preventable. Nobody can predict who will suffer from cancer. And if cancer happens, nobody can do anything right now. Okay. So the target of public health is that only. Okay. And the one जिसका इंसिडेंस हम घटा दे, वो हमारा टारगेट होना चाहिए. There are two things, prevalence and incidence. So we'll focus upon incidence, and by least effort, if we are able to reduce the incidence, we should focus upon that. Sir, one small request, could you please show ये वाला डेटा किस टैब में है? तो ये वाला डेटा, ये सारे आपके किस ओए के टैब में है? देखो, दो टैब है, एक द हिंदू क्लब हाउस वाला टैब है, ओके, और एक ओए वाला टैब है. Now those people who have paid me full, they are in this list, or I have added them to this. Otherwise, you are in GK wala group, edge pre wala group. This is ignited edge pre. This is ignited edge OPI. So this is in ignited edge OPI wala group. Okay, fine. So I will stop here only.